Greetings, GERO 200.
Hey guys.
Here. It is Sunday, September 17th, and we're taking a break from watching the 49ers game.
Or the Rams game.
Both, yeah. Anyway, cool game. The #1 draft pick quarterback versus the last pick in the draft the year that he was drafted, which is kind of interesting.
Yes.
Fun story.
Alrighty.
Anyway, so this week we're going to be talking about cancer and grief, and I have a special interest and a passion for both subjects. So I always say, John, can I be part of this video? And he says yes, because he always agrees with me.
Plus, she's my co-instructor. Also, just a heads up, guys. So you see September 20th. That's right around the bend, isn't it? It's Wednesday.
Yeah.
So along with this video, I'm going to be sending out a video that describes how to tackle this
Sorry, the dog's
exercise.
trying to unplug.
Okay. So I have a position right here. This is from last spring. The assignment is exactly the same, so I'm not going to make a new one. All right. And you guys are good with that. There's a complete list of directions right here. Okay. And then there's a slide deck. Okay. All right. And you'll see exactly what's going on there, and I'll be sending it out. Don't forget here's your developing countries. You know, you're going to compare it to the U.S. and another country. So
okay. So if you have any questions about CT1, you can email me. You can text me. If you have any problems submitting it through Turnitin, you can email it to me and I'll submit for you. If your computer breaks down, you can go to Levy Library and check out a computer in the basement. You can write it on your phone if you have to. You know, just try to get it in. It's 1 to 2 pages. We do not penalize you if it's longer than that.
It's going to be longer than that just because of figures. So.
Yeah, we don't expect you to do a lot of research. You can use Wikipedia. It's totally fine. But, you know, just try to talk about the data, compare the countries, talk about the data over time. The rubric gives you pretty specific information about what we're looking for.
Yeah, and you're going to be gathering your own data, which is you're going to do some data mining, which is the World in Data website is amazing. And
I love that website.
You're going to use it all throughout your lives.
I use it in my other classes to teach. You're going to have one graph on for one of the data sets that will allow you to put all 3 countries on it. But for the other data set, you will have to have a separate graph. So you'll have 3 graphs for the second data set for a total of, 4
yes, 4 graphs. So, yeah, so the part 1, you know, as you look at it, has 1 graph with the 3 countries, and then the other one will have 3 independent graphs. It's just the way it worked out. You'll see, all right? Okay. And that's it. So 1 is life expectancy, as you see right here. That's the one that you can throw everything onto one. And then the other one is looking at the relative relationship of working population to the people that are dependent on them for their well-being. Okay, all right. So that one requires 3 separate graphs. Okay. All right, you'll see later on when you check out the work. Let's go into our weekly assignments.
So cancer is our topic this week. I am a cancer patient. I'm in cancer treatment right now, so I'm pretty fired up to talk about it because I know what I'm doing. I have always been interested in cancer because a lot of people in my family have had cancer. And then I was diagnosed 10 years ago with leukemia, and I have a chronic type of leukemia that never goes away. So periodically I need treatment.
Like right now.
Like right now. So I'm over the worst part of treatment. The first couple months are pretty busy.
There's no free lunch, believe me, but at least it's not chemo. You know,
could be a lot worse. Yeah.
It's not, It used to, back in the day, it was they called it combinational chemotherapy. 3 very toxic drugs that were toxic to any cell that divided in your entire body. So people, you know, got really sick, and they still do for things like breast cancer, but at least this one is a little more targeted.
Yeah, and I'm very encouraged by the advances we're seeing in cancer treatment. In the 10 years since I was diagnosed, treatment has changed dramatically. It's completely been revolutionized in 10 years. Things that we could not even comprehend, like CAR T cell treatment, where you harness your own T cells to attack the cancer, are now pretty widely available.
T cells are your immune system cells, so you get your own immune system to attack cancer, which it does all day long, by the way.
I've had 2 courses of treatment. Neither one was chemotherapy. I use immunotherapy and targeted inhibitors. So I've been able to continue to work through treatment both times. So there's a lot of good news for cancer patients. Obviously, no one wants to get it. But if you do get it, then the good news is that there's a lot of good stuff going on in the research world. So
and I want to reflect it back to just the previous chapter when we did the biology of aging. Okay, so that was assignment 4. There were a couple of topics that were stressed in terms of how disease piggybacks on this process of aging. And one of the things that drive things out of whack are too much growth genes. Okay, too much nutrition causes an elevation. We saw in that chapter and in the video, too much IGF-1, and that is a hormone that basically says, hey, look at all the nutrients. Let's put it in every single cell we can, and let's undergo cell division. And but if you have too much nutrition all the time, then the driving it all the time, and Joe's going to talk about it later on. These normal growth genes are called proto-oncogenes, but you don't want to be doing that if you already have an out of whack growth gene, which is an oncogene. Yeah. Okay, so that and the other thing is that was in that chapter is speaking of out of whack, and out of whack DNA repair mechanism. So you're making mutations all day long. It's up to your body to go in there and repair those genes. These are called tumor suppressor genes, and we'll see from today's discussion those can go out of whack as well.
Okay.
All right, cool.
So two really great sources of information for cancer data is the National Cancer Institute, which releases it's called the SEER report every year. The 2023 report hasn't gotten out yet. It should be coming out probably next month. So we're using the 2022 report, which was released in October of 2022. The other source that I look at quite a bit is the American Cancer Society. They also publish data that's very interesting. And so what we want to watch over time is, what types of cancers are increasing, which types of cancers are decreasing, what do the death rates look like? And so that data is really important because as we make public health decisions and choices on treatments, prevention, et cetera, we can see an effect sometimes pretty rapidly. So this data is very, very important. When we talk about the incidence rate, we're talking about the number of newly diagnosed cancers in 100,000 people. So that way it's normalized. And when we talk about the death rate, it's again reported cancer deaths per 100,000 people. Now, it takes a little while for that data to be ready. So we're always looking backwards. So if you get diagnosed this month with some type of cancer, a family member gets diagnosed with some type of cancer, and you go on the internet and you Google life expectancy, you're going to get data that's not true for someone who's diagnosed today. The life expectancy that you'll see will be probably for people who were diagnosed 5 to 10 years ago with the treatments that were available back then. So when I was diagnosed, my life expectancy was probably like 5 years, and that was 10 years ago. So obviously things have changed. So don't get too scared if you go onto Google and look at life expectancy or prognosis. That data is always looking backwards. It isn't based on what's happening right now. So the good news is that cancer death rates have decreased, not just from 2015 to 2019, but I know over the past, say, 30 years that cancer death rates have been decreasing regularly. So that's great. It's decreasing a little bit more among males, 2.3% versus 1.9% among females. We're seeing a decline in death rates for adolescents and young adults. The big things that are moving the numbers are lung cancer and melanoma because we've come up with new treatments called checkpoint inhibitors. Keytruda, you might have heard of, seen commercials on TV for that harness your immune system, that allow your immune system to really get going against that cancer. And so we've taken these two cancers, metastatic melanoma in particular, and lung cancer, which may have had really poor prognosis, poor outcomes before, and now we're seeing people living much, much longer with these diagnoses. So that's really improving our death rates.
With the cancer cells, they're very nefarious, but they devise these methods. And so they have kind of like this Yoda way about them, where the immune system's always like, right now, as you're sitting here watching this, believe it or not, you're producing cancer cells. And then your immune system sniffs it out, says you don't look right, and it attacks and gets rid of it. And then what the cancer cells had devised was a protein that they would put on their surface, and kind of like Yoda would say, I'm not cancer. And then the immune system comes up, looks at that protein, says, okay, I'm moving on. And so the cancer then grows and you don't get rid of it. The other big thing Julie talked about too was public health and making big changes. And these two right here are, again, enormous changes just because of awareness. I mean, it seems so simple now, but hey, you wear sunscreen and you're going to reduce your likelihood of melanoma. You wear a hat, you reduce your likelihood of getting melanoma. And then, you think about lung cancer, everybody knows that inhaling cigarette smoke is a super high risk factor, and we saw huge declines because of changing in that. What we don't have with the 2019 data, we don't have what's going to be the new public health information for vaping. Okay, so
exactly.
We'll see, in a couple of years what the outcome is that.
Yeah, so we don't know yet.
Okay.
So keep scrolling.
Yes, sir.
Keep scrolling. Okay, so AYAs, adolescents and young adults, cancer death rates went down for them, and they went down a little bit more for children. We see a very high participation rate in clinical trials with children. So those children are getting the latest and greatest treatments. The last treatment I had, not this one, but the last one I had, my first treatment, was through a clinical trial. 2 drugs that were already approved by the FDA, but we were combining them for the first time. And it just turns out that combination therapy is much better than a single medication therapy for my disease. So I got a great result. Did better than expected with that 3-year treatment that I was on.
A lot of these childhood cancers are childhood leukemias, and they've made incredible progress with the white blood cell. Leukemia is an immune system cancer, so they've done really well.
So a lot of times, scroll back up just a tiny bit. A lot of times people will say to me, one of the things that bums us out about GERO 200 is you're telling us about all the problems, but then we're just sad and depressed. Well, the thing that's amazing and wonderful about learning about cancer is that we can dramatically affect all of our risk factors for cancer by doing some very simple things. Exercise, don't smoke cigarettes, eat healthy food, plant-based diet, Mediterranean diet. Drink moderately if you do drink, 1 drink per day for women, 2 drinks per day for men. Limit your sun exposure, wear sunscreen, things like that. Now, you're probably saying, sorry, I'm in college, I drink, I eat terrible food, I smoke.
And it's really,
it's okay.
It's not a one day, like, oh, that's it.
No,
this is over many years.
You have not ruined your life if up to this point you've been doing everything wrong. But let's say you're a smoker, maybe drink less, or let's say you drink a fair amount, maybe exercise more, maybe eat healthier. So you can balance risk benefit in each category, but definitely you will decrease your risk by watching those factors. So we definitely know there's this really tight correlation between smoking and cancer. And what I think is surprising, what I wanted to show you, is that it's not just lung cancer. We think about getting lung cancer if you smoke, but you can get cancer all through your throat, your larynx, your esophagus, your oral cavity, but also liver, cervical cancer, kidney cancer, stomach, bladder, pancreatic cancer. My dad was a smoker. He was also overweight, and he was initially diagnosed with kidney cancer, treated it, cured it. Then he was diagnosed with bladder cancer, was still doing pretty well, pretty stable, treating it, doing really well. Then he got diagnosed with lung cancer, and he lived actually for probably about 18 months to 2 years after his lung cancer diagnosis. Didn't die from the lung cancer because he had other problems. But I do think his smoking, he was a lifelong heavy smoker, contributed to all of those diagnoses, and our family history of cancer probably, helped out a little bit.
It's no big surprise when you smoke cigarettes. It goes from your lungs into your blood. Yes, there's immediate damage to the lungs, but it goes into your blood, and then anywhere blood goes, you get those toxins. So
yeah. So, and then we've got another little graph here that looks at the correlation when we look at cigarette sales and lung cancer deaths in the U.S. Because there are these different things that have happened. World War II, a lot of people were smoking, different things happened. Then all of a sudden we started passing laws that made it more difficult to smoke, increasing the taxes on cigarettes, educating people.
They stopped having commercials on TV.
Yeah,
they banned them.
You couldn't advertise cigarettes on TV. In California, quite a while ago, we passed rules that said you can't have smoking in public buildings or restaurants. So now we're getting rid of that secondhand smoke problem. And so you can see, you can almost overlap these graphs. They're almost perfectly correlated between sales go up, deaths go up. Sales go down, followed by a certain number of years later, deaths go down. So the evidence is very good for that correlation between cigarette smoking and deaths from lung cancer.
Here's the number of cigarettes per day. This is the rate on this scale. So there's 2 different scales, and on the bottom you see progress of time
Yeah,
up to
and that may be
2010.
why there's a slightly bigger dip in deaths among men than women right now, because maybe men are decreasing smoking a little bit. Men tend to smoke a little bit more than women in the US. So the other thing that's really important, and you're probably going to like this because college students tend to be more active, and Lord knows when you roll out of bed and you're running across campus to get to your class, you're physically active. You're incorporating activity into your everyday life. And a lot of you are very athletic, or you may be on sports teams at USC. So you're doing exactly the right thing to reduce your cancer risk. In particular, physical activity, we know for sure it reduces your risk of breast cancer. It reduces your risk of colorectal cancer. It reduces your risk of endometrial cancer. So if you have those cancers in your family, or you're worried about having those cancers, stay active. And, we walk a couple miles a day. We used to walk a little more, and then I started treatment and I got a little tired. So, but, anywhere from like 3 to 5 miles a day, we walk our dogs. It's super relaxing. We're outside in nature, so we're reducing stress and engaging in physical activity. And as I always joke with John, if I'm exercising, I can't be eating, right? So it's healthier for me that way too.
And how they figure this is a public health study, all right? So these are what are called public health detectives. They're called epidemiologists. And we talked about this on week 3. I said, so maybe someday you'll go work for some public health department. You go work for the RAND Corporation. You go work for the Pew Foundation. They do these kind of studies where they every time you go to the doctor, how you type in, or old school, you fill out a form and you list all of your behaviors, and then they put that into the cloud database, and they start analyzing the numbers. So data analytics, which is another job for you guys, and then they crunch it and they find out, hey, look at these are statistically significant trends for exercise that impacts these cancers. How does exercise do that? Exercise is just this really, really good kind of stress, but it is a stress. And then the body responds by upregulating its anti-stress proteins, these enzymes. So then when something nasty happens, so you do smoke a cigarette, you're more geared up. Okay?
Your immune system functions
to go
better.
after it.
Yeah.
So.
And so we were trying to get our COVID booster this weekend, but our insurance doesn't cover it yet.
Oh, whose insurance is that? Would it be USC's?
We were pretty salty about it. We got turned away.
Idiots.
However, we went for a walk beforehand, because if you go for a walk before you get a vaccine, it will help your immune response. So now here's the bad news for all you college students. Not all of you, but those of you who drink alcohol. Alcohol is correlated to a lot of different types of cancers, just like smoking cigarettes is correlated to a surprisingly big list of cancers. Alcohol definitely is correlated to colon cancer, rectal cancer, female breast cancer. And so, if you drink right now, you're 20, it's not going to make you have cancer.
It's the long haul. You don't want to be 10 years doing this.
And trust me, when you get out of college and you start working, you're going to have to get up early and go to work. You're not going to be able to really go to be at wagers, So life will change for you.
But there is a tendency to drown your sorrows, and so you have to.
John and I were having wine at 5 during the pandemic to just get through the day, and we've cut back.
That's a term of art, wine at 5.
It's part of a blue zone.
The blue zones. I suppose you're all about longevity. However, you don't want to overdo it. So
yeah. So these graphs show in red shows an increase, blue shows a decrease. So these are trends in rates of new cancer cases broken down by men and women. So prostate cancer increasing. Is it increasing because we have more cases of prostate cancer? Is it increasing because we have more people getting screened or better detection methods? Hard to tell. Women, melanoma of the skin. So probably related to sun exposure. All those fun days when you go to the beach or you're outside walking your dog. I'm guilty of it. I try to put on sunscreen now, but I probably should have tried harder when I was younger. And so we see some other things like pancreatic or liver cancer that are probably related to both alcohol consumption and obesity. So we see certain trends, kidney cancer as well as related to obesity. So we see certain trends that are very controllable risk factors, overeating, drinking, lack of exercise, et cetera. And then you look on the happy side, the blue things are decreases in cancer cases. So we're seeing
blue bars.
What did I say?
Things.
The blue things. It's a very technical term, the blue things. I'm allowed to use these technical terms. So anyway, the blue bars like cancer cases, new lung cancer cases are decreasing probably because people are smoking less. So, those are good things. So keep scrolling down. Now we're going to look at cancer death rates. So the good news here too is that we're seeing a lot of cancer death rates decreasing with blue bars, or blue things, as I like to say, and only a few cancer death rates that are increasing. Probably because we're getting more cases of those types of cancer.
Yeah, and when you look at this, like this bone and joint cancer, that's usually metastatic, right, from something else, or is that primary? I don't even
No,
know.
these would be primary cases.
Okay,
Yeah,
right.
yeah. And so, again, oral cavity cancers could be HPV, could be alcohol, liver is alcohol,
Pancreas is alcohol.
hepatitis infection, things
Yeah.
like that.
So,
Um,
and all sites, the black bar on average, we're
yeah,
doing.
and we're seeing, again, at the bottom, we see both for men and women, a dramatic decrease in deaths for melanoma and lung for both men and
Because
women
treatments are so much
because of
better.
these new treatments that are
So we
available.
may see a change in diagnosis, but if you get it, the treatments are better. So.
Yeah. Okay. Now, one of the things I have a lot of concern about is what's the effect of the COVID pandemic on cancer detection and cancer treatment? It was definitely difficult being a cancer patient during the pandemic. I had to see my doctor by Zoom instead of, well, whatever. It was some Zoom-like thing that was
WebEx?
HIPAA compliant. Um, and so he wasn't able to do a hands-on physical exam of me. So he couldn't really, normally when I go see the doctor, he checks my lymph nodes in my neck and he checks my lymph nodes in my armpits and he checks around to see, checks my spleen, checks my liver. But we couldn't do that during the pandemic. Luckily for me, it happened to fall in a time when I was in remission. But for patients who weren't in remission, it definitely made things harder. What I'm more concerned about is we got out of the habit of going to the doctor for our regular preventive care checkups, the colonoscopies, the mammograms, the prostate blood tests, the CT scans for people who are at high risk of lung cancer if you're a lifelong smoker. And so what we're probably going to see, if you scroll down, what we're probably going to see, unfortunately, is what we call excess deaths, more deaths than we would normally expect to see from colorectal cancer and breast cancers in the US because people were not getting colonoscopies and mammograms during the pandemic. If you have people in your family who are, say, over 40, ask them, have you had a mammogram? Is it time for you to get a colonoscopy? Some people are on like every 5 or 10 year schedule. I'm on a 3-year schedule because I'm special. But get those tests done. You get diagnosed earlier. A lot more treatment options. Sometimes it's a lot easier, better prognosis to get diagnosed earlier and treated earlier. Now, the other thing I'm really passionate about is inequity in treatment. And we see some inequity in treatment along sex, along racial and ethnic lines, along income lines. And so we have a lot of work to do because if we look at the incidence rate, which is how many new cases there are per 100,000, and then we look at the death rate, we can see in the incidence rate that white people have the most cases getting diagnosed per 100,000 people. But when we look at the death rate, it's non-Hispanic Black people have the highest death rate. So that is an issue of real concern. We've got to do a better job of early detection, prevention, education, community support, access to clinical trials, financial support. Being a cancer patient is no joke. I was talking to John one day. I'm a lawyer, so when I have problems with my insurance, I can lawyer up and I can make it work and I can get coverage usually. And I also have the kind of job where I work at home, 3 or 4 days a week, and I go into campus, 1 or 2 days a week, which means that the other day when I had to spend 2 hours on the phone with my pharmacy trying to get my cancer med filled, that was okay. There was nobody saying, hey, you can't be on the phone at work. I was able to get that done, and then I could go sit on my computer and grade papers or do whatever later.
It's USC's third-party administrator.
So,
So if you want to start a protest, most
But
expensive insurance that we can buy, they have this group called Navitus that is
the pharmacy benefit manager.
the pharmacy benefit manager, and they say no, 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 hoping that people die and then they won't have to pay. So it is outrageous.
My treatment's probably costing about $50,000 a month right now.
So
they are definitely hoping I die.
Yeah, but they made it. Most people are not attorneys. Most people would throw up the white flag and go, "Oh well," and go away. So
and so I really go back up. So and it's also broken down by gender, by sex. I'm sorry, I always get that wrong. By males versus females, and so you can look at the left side is incidence, the right side is deaths, and you can look to see, Black males have a higher incidence than, say, Asian Pacific Islanders or American Indians, Alaskan Natives. And you can go through and look and see which groups are potentially more at risk. We have seen in the past that Hispanics, recent immigrant Hispanics, are lower risk, but as you watch this community, people from all over the world move to the U.S., and they have these really great diets and really healthy practices and all these really good things going on from where they come from. They come to the U.S. and then they become assimilated, acculturated, whatever, into U.S. culture. They start eating fast food, drinking, smoking, and then within a few generations, then their risk tends to go up. So that's a public health concern right now.
The exercise lasts on the all night.
Yeah.
And going back to our first, when the shows because I had it up there. Going back to our first, our previous week about biology of aging. When you are obese and when you eat too much food, bottom line, it's overnutrition. You have higher levels of IGF-1. Here's a study that looked at 400,000 people, and again, from this transition that Julie's talking about, this cultural change of going from the family values and the cultural values of the roots that you grew up with in Southeast Asia to becoming a true American and eating crappy food. That's the outcome.
Yeah. So what we really need to do to help reduce risk for all types of people that are in higher risk groups is make sure they have access to fruits and vegetables and healthy foods and fiber and things like that.
So this is more verbiage describing the inequities, health inequities in terms of cancer.
There's also other issues, especially in the Black community. If any of you have heard of the Tuskegee syphilis experiments, that was a famous experiment that ran from, say, 1930 to 1970. And Black people in Tuskegee were initially, they were just studying people who had syphilis. And the next thing you know, they were giving people syphilis. Their family members were getting syphilis. There was a treatment available by, let's say, 1940. But the patients who were participating in the study were not told about the treatment. And so this affected many families and many lives over, say, 40 years. And the aftermath of that is a lack of trust in the medical establishment. Right. So we've got to really work hard to overcome that. So anyway, so let's go up. Sorry.
That's,
the last thing, not the last thing, but one of the other things I wanted to preach about today is the HPV vaccine. As a cancer patient, if someone had said to me, and they are working on vaccines for all different types of cancer, and there's a lot of progress being made on that. If someone had said to me when I was 20, hey, we can give you a vaccine and it will keep you from getting cancer when you're 50, I would have said, where do I sign up? We have really good data out of Australia, because they're a little bit ahead of the US in terms of rolling out HPV vaccines, that we see a big drop in the types of cancers that are related to HPV. So it's human papillomavirus, sorry. People always get it confused with herpes. Human papillomavirus. Now, you're probably thinking, oh, I don't have HPV. I am a nice person. HPV is pretty much everywhere. By the time you're my age, you've almost certainly been exposed to it. Some people get exposed to it and they clear it. Some people get exposed to it and they don't clear it. And so it's unless you are literally like a nun living in a place with no contact with anyone, you are going to be exposed to HPV.
So this is cervical cancer, that all these graphs, and combined all the races and then broke it down by white, Black, and Hispanic.
Yeah. So when our sons, we have a 27-year-old and a 22-year-old, when they were coming of age, the pediatrician suggested that we get the HPV vaccine. I looked into it and I said, there was just starting to come out with data that showed that the HPV vaccine, not only did it prevent cervical cancer, so it would have been a nice thing for them to get vaccinated, but it also prevents oral cancer, rectal cancer, anal
throat
cancer,
everything.
all kinds of throat cancer.
Because anywhere that virus, it gets in there and then it pirates your DNA, and then next you know it's doing what the virus wants you to do, which is create a cancer cell. So.
Yeah. So I mean, nobody wants to have their tongue removed or their rectum removed. It's not a fun thing. So I'm just saying, if you haven't been vaccinated against HPV, think about it. Just consider it. Look into it, research it, decide what's good for you. But it would make me happy if I could prevent some cancer cases among the class 40 years from now. Okay, so we've given you a little information from the National Cancer Institute. There's a cool video, and basically the video talks about what cells are like, and if you've had biology, this will be pretty basic to you, but it talks about the fact that, in cancer cells, you have some sort of mutation that takes place. Something happens to a gene that causes that cell to divide and to grow without any checks on it. So a normal cell would sit around and say, oh, I'm waiting for a signal to grow, or I'm waiting for a signal to divide. But these cells are like, grow, 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 divide, divide, divide. And that's how you get tumors that get really big, really fast if it's an aggressive cancer. Cell death is a fancy term, apoptosis. So we are looking in cancer treatments to find things that will improve apoptosis of cell death. Typically with cancer cells, with normal cells, when they get old and frail and messed up, the natural course of events in the body is that you have systems in the body that are like garbage collectors, and they're like, okay, time for you to die, and then we'll clean you up and take you away. But with cancer cells, that doesn't work very well. So treatment is usually focused on decreasing cell division and increasing cell death.
And you have these, basically these proteins in every cell that screen and say, you don't look right. And they're checking the DNA. They'll try and repair the DNA, and then when they can't repair the DNA, they set into motion the cell death, which is apoptosis.
Yeah.
And these are called, as shown up here, these are called tumor suppressor genes.
Yeah.
So you put the brakes on cell division, all right, and you go in there and you check for problems. If there's a big problem, that's it, you're done. And these guys are the growth genes that when I talked up here about IGF-1 from overnutrition, that is IGF-1 is a hormone that we normally produce. It says there's a lot of food around, go ahead and grow. And there's different rates of cell division. Some cells, like in our gastrointestinal system, there's turnover about every 20 days, I think, if I got it right. The mind-blowing statistic is, we produce billions of brand new white blood cells and billions of brand new red blood cells every single day. So there's a lot of gas, to the pedal to the metal for cell division there. But even then, you can get too much, which is the case. You could see it in her white blood cell count. All of a sudden, it really takes off. It's like maybe 10 times what it should be, and it's because it's producing cancer.
I'm a data person, so not surprisingly, I have all these Excel spreadsheets where I look at my blood work and I predict what's going to happen in the future. So, okay, so let's talk. Let me see if I missed anything. We talked about proto-oncogenes and tumor suppressor genes. So let's talk about grief. I want to say about grief, there's no right or wrong way to grieve.
It's a good video to watch, by the way.
This is one of the classic people in grief is Elizabeth Kubler-Ross, and she talked about the phases of grief, and so she has this scheme and this framework where it's denial, anger, bargaining, despair, just depression, acceptance. And you may go through these phases linearly. You may skip around. You may go from denial to bargaining, back to anger, to depression, back to anger. When you lose someone that's important to you, and it doesn't have to be a death. It can be someone who's unavailable to you. Maybe you've ended a relationship. Maybe you have a loved one who is mentally ill or unavailable because they are a drug or alcohol addict, and they're just in a different headspace.
You lost your job, or maybe you're like, what are you going to face? You're going to be sending in applications, get excited, and then find out you didn't even get an interview.
Yeah.
You're going to go through the same thing.
Yeah. And so there's a lot of different types of grief that you can experience. And like I said, there's no right or wrong way to do it. You may find that two people in the same family grieve very, very differently. And it could be because of the stage of life that they're in, and it could just be their personalities. And so it's always kind of nice to just give people the space to grieve the way they are going to grieve. Some of the things that I've found helpful, when my mom passed away, it was sudden. And I was crushed because I was really close to her. She was really important to me. And we tried to do some of the things that she liked to do. She was a gardener, so we planted a hummingbird garden out in our backyard. I would cook her recipes and think about her and remember her. And first couple of years, it was really hard. And then now it's become easier so that when I'm doing these things, I just get, kind of a warm, happy feeling. But I still, to this day, it's been, 4 or 5 years since she passed away. If I walk into Home Depot to the garden section, or I walk into Michael's to the craft section, because she was very artsy craftsy, I kind of get like, I miss my mom. So it's a process, and grief is not something that you're going to get over in 24 hours or 2 weeks or 2 months, but it gets easier with time.
But it's okay if you go through it quickly too.
Yes, yes.
I was one of those. No, I just,
and this is what I mean. Different people grieve differently.
My mom died when she was 95. She had about a year and a half of just serious tailspin, and hospital visits and doctor visits and da 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 da. And I'm working up at USC. I live in Laguna Niguel. She's staying with my brother in Brea. So there was this triangle that I was driving, and it was just wearing me out.
It was very hard to see her lose her independence.
It just wasn't.
Too.
And so when she, I was actually had this huge sense of relief when she was.
Yeah,
when
and that's
died.
okay too.
So
that is normal.
I was pretty good with it. So.
If you are a caregiver for someone who's going through a really significant illness, it's normal to feel relieved when their suffering is over. Right. So anyway, so for the discussion, if you don't want to talk about it in the public forum that is the discussion forum, you can email me and I can give you an alternative assignment. What some people will do is that they'll respond to other students. They'll do their 3 responses to other students, but then they say, you know what? For some people, sadly, you've lost loved ones during the pandemic or for other reasons, and they say, my dad died last year, but I really am not ready to talk about it. So can I do something else? That's totally fine. We get it. We understand that. So we want you to do what you're comfortable with. The due date's still the same. But let us know if you need anything, and if you have any questions, we're always here, right?
Very cool. All right. Peace, guys. Take care, and we'll see you next time.
Right on.